evening, everyone, and welcome back to this week's installment of the Clinix Health Group's webinar series. My name is Dr. Mahlangu, or Dr. Mo, as everyone calls me, and I am the Chief Medical Officer for Clinix Health Group. I'd like to introduce to everybody a well-known guest, but he's back by popular demand. We were requested at his last presentation to bring in more orthopedics topics, and we thought, why not bring back Dr. Nevondo? So, Dr. Nevondo is an orthopedic surgeon currently practicing at Clinix Health Group's Tepo Temba Hospital and BH, and I think all of our hospitals, if I remember correctly. And he is a member of the South African Orthopedics Association. Dr. Nevondo obtained his MBCHB in 2008 from the University of Pretoria. He then completed a fellowship of the College of Orthopedic Surgeons of South Africa and College of Medicine in 2018. He further completed his Master of Medicine at SMU in 2019. I'd like to give a warm, resounding welcome back to Dr. Nevondo, whose topic today will be on multiple myeloma. Take it away, please, Doc, and thank you. Doc, you're muted.
Oh, I'm unmuted now. This table is low. Good morning, everybody. Is it morning? I mean, good evening, everyone. I am Lindelani Nevondo. I'm an orthopedic surgeon. And exactly today, I realized that I really am an orthopedic surgeon. The topic I chose today is way too big for me. I'm going to be presenting multiple myeloma. The reason why an orthopedic surgeon is presenting multiple myeloma today is the patients, when they come to present with multiple myeloma, their biggest presentation is that of bone pain. And in majority of patients that are in the township or the low socioeconomic status patient, when they present, they usually have a pathological fracture. So despite multiple myeloma being an immunological disease or a hematological disease or a physician's problem, it ends up presenting first to an orthopedic surgeon. And if you jump on a multiple myeloma patient and you operate them, you will have a beautifully reduced fracture and a dead patient. So it is an important topic, not just for orthopedic sake, but for everybody who is listening. Because at one stage you will meet this patient and they'll present with different things or differently, be it a reduced immunity, be it anemia, be it a bone problem, renal problem. So they can present in different faculties or institutions and places. So, okay, let's start with multiple myeloma. So really, what is multiple myeloma? And from the word itself, it says multiple and it says myeloma. The word myeloma coming from the word myel, which means bone marrow, can also mean spinal cord, but in this case, we're talking about bone marrow. And then you have the word multiple, which in this case can mean a number of things. Number one, it can mean multiple, meaning the multiple lesions that you see when you do an X-ray. Or the multiple here can mean the multiple or the plasma that you find in the bone marrow that are multiple. Okay. So looking at a number of journals that try to describe this condition of multiple myeloma, you have from the pathogenesis and treatment of multiple myeloma by Young et al. They say it's a disease characterized by clonal expansion of malignant plasma cells that accumulate in the bone marrow. So the word that you find there, you'll find the word bone marrow again, which is myel, and you'll find malignant plasma cells. So something goes wrong with the plasma cells that they start accumulating in the bone marrow. And then if you read on the orthopedic Bible, which we call ortho bullets, they say multiple myeloma is a neoplastic proliferation of plasma cells that commonly results in skeletal lesions, hypercalcemia, renal insufficiency, and anemia. So you can see it presents in a number of things. So there's anemia, which is usually a moderate anemia. There's renal insufficiency, which is usually what kills the patient majority of the time. There's hypercalcemia because of the bone resorption. There's skeletal lesions because your RUNCA1 is activated, which end up causing your osteoclast to resorb the bone. I'll go through that in a later stage. And for orthopedic sake, these patients usually present with localized bone pain and pathological fracture, and they're usually around the age of 60. And then there's also an article by Blade et al., which says multiple myeloma is characterized by neoplasmic proliferation of plasma cells or plasma cell clone that produces monoclonal immunoglobulin. Now, when you see this presentation, I mean, this definition brought another different word, which is monoclonal. So the word monoclonal have got the word clone to it. So it's one immunoglobulin or one immunoglobulin that is reproducing itself over and over again from plasma cells. So all those topics, all those three definitions that I brought up, they say that it's malignancy in the plasma cells, that they all agree to that. And then they say it accumulates in the bone marrow, and they are saying it's found in multiple bones. So that's where the multiple can also come from. So it can be multiple bones, it can be multiple lesions, or it can be multiple plasma cells. But those three definitions that I brought up, they kind of summarize to this slide. So we have seen that this whole multiple myeloma come from plasma cells. Something goes wrong with plasma cells. So really, what are plasma cells? So in terms of structure of the plasma cells, you find them in the plasma, obviously. They are large lymphocytes. They actually B lymphocytes, and they are abundant. They have an abundant cytoplasm. As you can see, that's the whole cytoplasm that they have. But they also have a very large and eccentric nucleus. They are also called B cells, and they got many other names. And the other thing that you see with this is when they have multiple myeloma, they now get a clock-shaped appearance. I'll come to that just later. And what they do, they produce antibodies, IgG and IgA. And this is another picture showing a plasma cell with multiple myeloma. You can see a large nucleus. You can see a large prominent nucleus that is sitting eccentric on the side. And you can see the cytoplasm also. I'll show better pictures. And then, so what are the functions of these plasma cells? Like I show above, they are found in areas where an antigen is likely to enter the body. So it will be in your mouth, you'll find them in the salivary glands. In lymph nodes, you find a lot of B cells or plasma cells. The GIT, which is also not a clean place, you find a lot of plasma cells. And then the respiratory system also have a lot of plasma cells. Their function, again, is to produce antibodies. So this is an example of an antibody that is produced by plasma cells, as you can see. They have something called a light chain and a heavy chain. Important when you talk of multiple myeloma, because these heavy chains is what causes the problem, especially in the kidneys. They clog the kidney. So how common or how famous is multiple myeloma? It is the most common primary bone disease. Like, it is the most common primary bone disease. It affects if you take 100,000 people, 3 to 4 people will have multiple myeloma. It consists of 1% of all malignant disease also, which is 15% of all hematological malignancies. So it will be in hematology, it will be in orthopedics, and it will be in other diseases, in other conditions. So majority of patients that get multiple myeloma are between the age of 40 and the age of 80, with the mean age at 60 years of age. Males are more affected than females. And it is one of those diseases which I think we can call it a black disease because it affects majority black people, followed by white people. It's rare in Asians. And in America, when they were doing the study to check who is affected, they find it is highest in Black Americans. But that's the group that is affected by multiple myeloma, the highest actually in the world. But it's blacks, whites, and then Asians last. So what are the risk factors of getting multiple myeloma? When you are advancing in age, 40 going upwards, if you are you are black from your race. If you're a male, obesity is also a risk factor. Acquired immunodeficiency disease, which also affects your immunity, will also increase your risk of getting multiple myeloma. And the family history of having lymphatic problems or multiple myeloma can also predispose you to multiple myeloma. Okay, so that was just a few words on what multiple myeloma is and who get affected by multiple myeloma. So now, when you have a patient with multiple myeloma and they present to your clinic, I think the word that was drummed into all our heads as doctors was CREB. We all had to know that like multiple myeloma was almost equivalent to CREB. But what does CREB mean? So the B in CREB means bone marrow. So multiple myeloma is from plasma cells which come from the bone marrow. So it affects the bone marrow. It causes a lot of plasma cells to be in the bone marrow. And the bone marrow invasion also causes the osteoclastic activity to be activated, and that is via the renal system. And that will cause osteopenia. It will cause punch-out lesions, which you can see on the diagram there. I just tried to put one which shows punch-out lesion. And it will also reduce it will affect mostly the weight-bearing bones predominantly. And then when the patients have had multiple punch-out lesions, they end up with pathological fracture, which can be either commonly in the humerus or in the proximal femur, and also in the spine. And then the patient, the main complaint early in the disease, they complain of bone pain. So they'll have deep-seated pain in the bone, and it will be in multiple bones. So it will be generalized bone pain. In CREB, the A stands for anemia. So it's usually due to abnormal utilization of iron in the body, but it can also be due to hemolysis that can happen, and it can also be because the bone marrow bone marrow invasion, which leads to this. And then the R in CREB stands for renal complications. So these patients, when they present, they will have renal problems. And the cause for their renal problem is the light chains and the heavy chains, but usually the light chains which get into your glomerulus and they go down the loop of Henle and they cause cast. So they actually sit and clog up together and they cause decreased urine coming out of your kidneys. The other way that renal complication happen is by hypercalcemia, because there's a lot of calcium being absorbed from your bone by your osteoclast. It end up clogging your kidneys. So you end up with hypercalcemia. And when you have hypercalcemia, if you take urine, you're going to find hyperuricemia. And then also the renal complications can also be due to plasma cells themselves invading the kidney. And for this patient, dehydration is high. In terms of treatment of patients with multiple myeloma, the first thing that you actually need to consider is to treat their dehydration, because that's what usually kills them. And when you're treating the dehydration by giving them fluid, you actually are washing out the kidney of the casts that are formed by your light chains. And then multiple myeloma also affect the nervous system. Remember I said it affect the bone. When you have a spinal cord compression or spinal bone compression, you end up with compression of your spinal cord itself, which leads to paralysis, paraplegia, and many other conditions that we don't really want. And then you can also get peripheral neuropathy, and you can get radiculopathy. And this patient can also get confused, usually due to the kidney problem, but also due to the plasma invading your CNS. Because it's a bone problem, it doesn't just affect the plasma cells, it affects all the cells, including the clotting cells in the bone marrow. So you end up with either bleeding disorders or thrombosis. So you can have two opposite things happening at the same time. So when you have had a patient with increased, with high risk factors for multiple myeloma, you have a patient that you suspect has got multiple myeloma, you've taken your history and the history is suggestive of multiple myeloma, then how do you confirm the diagnosis? So what investigations do you do? There's a lot, but in terms of blood, when you take blood on patients with multiple myeloma, you will obviously first take FBC and UNE. In terms of anemia, this patient usually have a mild to moderate anemia. And the causes of anemia I mentioned about it will be either your hemolysis, or it will be because of bone marrow invasion, or also because they are not utilizing their iron. So they can have iron deficiency anemia or hemolytic anemia. When you take your UNE, they will show you that they are having renal failure, be it end stage or it's still growing. And then when you take your CMP, you find they have hypercalcemia because of the absorption of calcium from the bone. And they usually have an ESR of about 50, and they also have hyperalbuminemia. They have low albumin, sorry. And if you take blood and you send it for protein electrophoresis, which is SPEP, usually you're gonna find they have something called an N spike, where they have a whole lot of IgG, like more than 50% of the antibody that you'll find will be IgG, and then 25% will be IgA, because they are usually monoclonal. And then when you take urine from this patient, you're going to find proteinuria. And if you do urine protein electrophoresis, you're going to find presence of Bence-Jones protein, which will show you your kappa and lambda chains. And you will find signs of either end-stage renal failure or just renal failure. So what radiology do you do on patients that you suspect of multiple myeloma? The mainstay in terms of radiology, the mainstay is actually just X-ray. Your X-ray that you do when you suspect this patient, you do a skeletal survey. And when you do the X-ray, there's 4 types of bone changes that you can see on X-ray on patients with multiple myeloma. So you can find multiple myeloma in one bone in one area, where you find multiple punctured lesions, say in the proximal humerus, but it's only that part affected. That we call it solitary plasmacytoma. So it's when multiple myeloma is in one bone, it's called plasmacytoma. Then you can find diffuse disease, which is the picture that we all know, that we have seen either in textbooks or in patients. And then in patients with multiple myeloma, the osteoclasts, which cleave the bone, is activated, but the osteoblasts are not activated, almost like the first stage of Paget's disease. So you will not find any sclerosis. So the lesions that you see will not have a sclerotic rim. They'll just be punch-out lytic lesions. And the patient will usually also have generalized osteopenia. So the punch-out lytic lesions that you see, you only see them when 50% of the bone has been destructed in that area where it is. And they're usually multiple in many areas, and they have no sclerotic border, again, because your osteoblasts are not activated. So when you're doing your skeletal survey, the the x-rays that you do is your skull x-ray, chest x-ray, pelvic x-ray, spine x-ray, and long limbs. So you almost just do x-ray of the whole patient. And even on the diagram that I put up there, you can see the many lesions that you see on the patient. And this is a pelvic x-ray where you can see proximal femur lesions, both sides. You can see lesions on the pelvis, on the iliac, on the pubis. And if you do x-ray of the long bones, you see all the lesions there. You can see there's no area of sclerotic around the lesions. Even on the previous picture, there's no area of sclerotic. It's just lytic lesions, lytic lesions, lytic lesions. And the one presentation that you get the most is the patient will have pathological fractures. And again, in the pathological fractures, this osteoblast really get activated. So you won't find pathological fracture with a lot of calus in it, even if the fracture is old. So other radiological investigation like your MRI, your bone scan, your MRI, you can do it for pelvis and spine, especially for spine if you want to see your spinal cord or if there's a spine fracture and you want to see if there's nerve compression or there's spine compression, whether you have your coda equina or any of those spine conditions that you need, then you do an MRI also in the pelvis to see. It's not necessarily to make a diagnosis, it's to plan your treatment or to define your diagnosis, which you will probably have gotten from an X-ray. Now, bone scan is not useful in multiple myeloma. There is a bone scan that is specific for multiple myeloma, but it is too expensive and it's rarely found anywhere. Because bone scan itself relies on osteoblastic activity. When you give a patient radioactive iodine or technetium scan, whichever you give, you are giving them, and then you are checking where the patient is, where the bone is rapidly growing, should I say. Now, with the absence of osteoblastic activity, in 30% of patients that you do a bone scan, it will actually be cold, whether you see nothing. It just looks like it's normal, or there's no any osteoblastic activity. So to make a diagnosis of multiple myeloma or to make a diagnosis of any other cancer, the only person who can make a diagnosis, it's a pathologist. So you have to take a biopsy from the patient, and probably that's the worst part of it, because usually the biopsy is done under sedation and it's done semi-sterile. Whether you get it from the iliac or you get it from the proximal humerus or from the proximal tibia, it's up to you. But when you have done the histology, what you're going to find, round cells with an eccentric nucleus which is prominent, and they will have clock space arrangement of the chromatin. So you will find plasma cells, but you'll find a lot of them, and they will have invaded the whole bone marrow. So how you take your biopsy, you can take it at different sites. It's not the nicest of things. So you actually need this large bore needle that you shove into the bone. Luckily, the bone is not as hard as it's supposed to be. And once you have aspirated, you send it for pathology, then they give you the results. And the results usually look like this. So you get a slide which shows you pink, purple, and white. That's how I know it. But you see all these plasma cells that have invaded the bone marrow here. In this zoomed in picture, you can see that's a cell, that's a cytoplasm, and that's a nucleus. You can see the nucleus is big. You can see that one is probably the best example. There's a big nucleus, which is sitting eccentric, and that's the cytoplasm. So you see all these plasma cells that are invading the bone marrow. So the pathologist will give you a diagnosis. Okay, your patient has multiple myeloma. Or they will give you a diagnosis is the patient does not have multiple myeloma and they'll give you that, then you have to think of all the differential diagnoses of multiple myeloma, which is vast, but it's usually almost hematological conditions that you have to think about. And once you have gathered all this information, you have had your history, you've had your investigations, and you end up with a biopsy, then you have to make a diagnosis. So what do you say? Does the presence of plasma cells in your blood says you have multiple myeloma? Not exactly. Does hypercalcemia says multiple myeloma? Not exactly, because there are many other causes of all those. Does having anemia, monocytic or hemolytic says multiple myeloma? Not exactly. Does all of them says multiple myeloma? Probably not. So those questions were asked over and over, and people ended up with diagnostic criteria. The early stages, we had the jury salmon diagnostic criteria, which you have to find one major and one minor, or three minors to make a diagnosis, and also two stages, to stage 1, stage 2, stage 3. In the end, it was confusing, and you have to know a number of values. So I think 2019 or 2009, they ended up coming up with the Jury Salmon Plus, which incorporate MRI into the classification in patients who have no lytic lesions. So stage 1 was patients with 0 to 4 lytic lesions with mild or diffuse changes on MRI. And patients with 5 to 20 lytic lesions were stage 2, and they'll have moderate changes. Those with severe changes and more than 20 lesions were in stage 3. So that's how you actually stage them according to the Jury Salmon Plus. But again, this is just staging. In 2009, there was the revised diagnostic criteria to make a diagnosis of multiple myeloma. So you needed all of the following to be met to make a diagnosis. You needed a patient who will have monoclonal plasma cells on biopsy, and it must be more than 10% of the biopsy. And then you needed a patient to have monoclonal protein detected in their serum or in their urine. And you also needed evidence of organ failure. So once those three are met, then you say multiple myeloma. So the evidence of end organ failure, I think I went through them before, but it's having high calcium, which comes from your bone resorption. It's renal failure, which is caused by your light chains, and also your deposition of your plasma cells in the kidney. It's anemia. It's bone lesions that you will see on X-ray, and if you're lucky enough on MRI. And then you need to have 2 severe infection in a year, or you need to have hyperviscosity syndrome or amyloidosis. So when you have one of those, when you have 3 of those, then you can diagnose multiple myeloma. So the 3 things is monoclonal plasma cells of more than 10%. It's monoclonal protein that you find either in urine or in serum, and also evidence of organ failure. Those 3 makes the diagnosis. And this one was easier to deal with, and it's currently the one that is used to make a diagnosis. Now, to prognosticate multiple myeloma, there's the new international staging system for multiple myeloma. So if you find a patient with serum beta-2 microglobulin of more than 3.5 milligram per liter, or a serum albumin that is more than 3.5, those patients have a median survival of 62 months. So probably the survival is not that high. It's the highest in this case, but once you find it, you are actually on the lower side. Those who have serum beta-2 microglobulin of less than 5.5, of more than 5.5, so they have a lot of microglobulin, then the survival, or the median survival, is usually 29 months. So in terms of multiple myeloma, once it's diagnosed and you have the bone lesions and you have the renal failure, the prognosis is not so good. going towards the end. So now you have a patient with multiple myeloma. They come to you with complaining of bone pain. They come to you complaining of pathological fracture, or they came to you with signs of end organ failure. And then you have taken the history, which suggests they have multiple myeloma, and your X-ray showing you all those lytic lesions, and your pathologist confirm you have multiple myeloma. So what do you do with the patient? The important part of this is this is not a patient that you are going to treat as an individual. You're not going to treat a multiple myeloma as an orthopod by yourself, because the only thing that an orthopod can do is to hammer the bone. And then after that, what? So this patient needs multidisciplinary team approach. So they need the physician, they need the nursing team, they need the hematologist, they need the renal, the nephrologist, the orthopod, and everybody else need to be there. So in terms of treatment of this patient. So the treatments that you do, you have fluid resuscitation, because that's their number one biggest killer of patients with multiple myeloma. Then you need to treat the hypercalcemia. Then you need pain treatment, and you need fracture stabilization, which is the part that I only know. And then you decide if you're doing stem cell replacement. I'll come to that just now. And then, sorry, MRI. Okay, and then chemotherapy. Go. In terms of resuscitation of this patient, this is a patient that need to be treated by a person who's confident in giving fluid. Usually they need a physician, because they got both renal failure and they are dehydrated and they got hypercalcemia. So you need to know what fluid you're giving them and why you're giving them. So the fluid usually is to flush the kidneys to reduce the calcium. And then you also have to treat the kidney themselves for hypercalcemia. You have to treat the kidney for the casts that are formed. So fluid resuscitation is probably the mainstay or the most important part of treating this patient. Then you have to treat the hypercalcemia. Like, it is also treated by fluids, but this patient can also be put on bisphosphonates. Bisphosphonates will actually reduce the activity of your osteoclast, thereby reducing the amount of calcium that is being released from your bone. So you will actually have less calcium, and it will actually reduce the chances of the patients getting pathological fractures. And then you have surgical treatment, where it's you do stabilization of your fracture. So the first part of it is, as an orthopod, you'll probably be called, but most physicians anyway do the biopsy themselves. But if you do biopsy, you'll be called to do a biopsy. But what we called mostly for is to do fracture stabilization. So when a patient has multiple myeloma, usually you don't put a plate, because a plate usually fits a smaller area. You put a nail on this patient, like I showed on the graph there. You put a nail because there's a high risk that where the nail ends, like down here, or where the plate end, or where the implant end, it becomes a stress riser. So if you put a short nail, will have a stress riser, they have a fracture, they have a fracture, they have a fracture there. So when you put a longer implant, you are reducing the chances of a stress fracture. And you're also reducing the chances of fracture due to the punctured lesions themselves. So the orthopod's job in this case only comes when you have to do fracture fixation. But I mean, it's a team approach. What did I forget? I think that's the end of my talk. Thank you.
Thank you very much, Doc. Right. From me, oh, all right. We have a question from Faith. What makes Blacks or African patients more at risk than other races? I'm not too sure if you read into
I don't
that.
know. Look, the reality is there's a lot of diseases that we have been singing. This is a white disease, diabetes, white disease, hypertension, white disease. So many diseases we call white disease. I guess we have to add one yana, So the reason behind it, there isn't a reason behind it. But there is a dietary thing about it. People who eat a lot of fish and a lot of vegetable, they actually at low risk of multiple myeloma. Second thing, obesity is also one of the causes of, or one of the risk factor. And the study, remember, it was done in Black Americans. They are big. So other than that, I don't know anything else that is like responsible on why the disease is high in Blacks.
I think also in South Africa, with our growing obesity rates, it's something else that I think is very important for a lot of us to look out for, because the last statistics that were released, and I think we've said this previously in another presentation that we did with Prof. Ngomezulu, was that there is a 17 that Black women, actually African women, 79% of them currently of the population is sitting at overweight or slash obese. So I think that's also something we need to look out for.
And also being from low socioeconomic status countries, HIV and AIDS is high, which affect your immune system, which also increases the chances of getting multiple myeloma.
That's very true. That's very true, considering our HIV rates, just based on what you presented with the prevalence in HIV. And I was just looking at the blood results you were showing. I assume that means that a lot of the times when doctors do their normal follow-ups with patients, they need to pay close attention to your FBCs and the other bloods that you presented earlier on.
Yeah, that's correct. I think for majority of patients that comes and consult and you suspect any tumor, even if it's benign, it's a good habit to do an FBCU and ESR-CRP. If it's normal, perfect, but it gives you the baseline. If there's changes next year, then at least you know which direction it's going. So just basic blood can play a big role, even though they are normal in the beginning, but as you go, then you're able to monitor the progress from there going on.
Thank you. I don't know if it's possible if you can just go back to your previous slide. I'm not too sure if you mentioned that in terms of your pathological fractures, and you said here we don't put plates, you only put in screws.
No.
You see,
Like,
the last time I did orthopedics was internship.
so you totally avoid, like you have a patient with the whole bone, it's got a small little lesions. Even if I fracture my arm there, you don't want to fix there because the whole arm is affected. So you want to put something that cover the whole thing. So a nail, not a plate.
Okay.
Not a screw, a nail. Yeah.
Right. And then in terms of post-op and your incidences of non-union and malunion in terms of complications for this patient, I would assume they're quite high in multiple myeloma patients.
Your assumption is correct, because these patients have got no osteoblast activity. So they don't really form bone. When the bone has to heal, there's like stages of healing of bone. So first is you get blood rushing to the area, bringing all the nutrients. Then you get your osteoblasts coming to lay bone, and then your osteoclast at last will go and remodel the bone. But in patients with multiple myeloma, hardly their osteoblasts hardly get activated. So they fracture don't heal as good as they are supposed to. They do have some healing potential, but it's lower, which also goes back to the last question. That's why you put a longer plate or a long nail rather than a small implant.
All right. So you see, I still remember some things from
Yeah.
in not bad. We have a question here um from from Dr. Kinoshi, and he said, you said you'd come back to stem cell treatment, but I think you forgot. What is the latest area in terms of stem cell treatment in multiple myeloma? Availability of this mode of treatment in South Africa and perhaps internationally. So let's start with stem cells. Is that currently used?
Dr. Kinoshi, I did not forget. I kind of ran away from that question. And I knew I am going to fluff it around. But in terms of stem cell, it's actually one of the fastest growing things. It's becoming the mainstay treatment for multiple myeloma, even in South Africa. So when you treat those patients in terms of stem cell, all the decision you make is actually is this patient can they go to theater and get stem transplant? Like, are they physically fit for that or not? That's the decision you actually make in terms of treatment. If they are not fit, usually when they're above 65 and they're not that fit, usually you start them on chemotherapy. But the aim again is to stabilize them enough for them to get stem cells. Because without stem cells, there's hardly much you can do with patients with multiple myeloma. The thing that I keep telling the students when I teach them is, I think in the next few years, multiple myeloma will totally become a physician's disease where you come, you get chemotherapy, you get stem cell, and you're healed. Hopefully, it will be like that. So, stem cell, it's growing, and the thing that is growing even faster with stem cells is chemotherapy. I didn't even list the amount of drugs that you can give for this patient. There's a long list of drugs that are coming in terms of chemotherapy to reduce the craziness of their plasma cells. So it's a growing entity of stem cell, and I think it's going to become the mainstay soon. In some hospitals, even in South Africa, it is the mainstay treatment.
Okay. Thank you very much. Thank you for that, Doc. I don't see any other question. Oh, never mind. Here's one from Dr. Khadepe. Can it be diagnosed early before the age of 60?
Yes, sir. It can. The mean age for multiple myeloma, it's 40 to 80 years. The mean is 60 years. Start usually around the age of 40 and going on. But again, remember, all those risk factors that I mentioned, they are not, age is one of them, but there's obesity, there's RVD, there's diet, and there's none, and it's not limited only to old people. And on top of it, there's a growing phenomena where younger people are getting older quicker. So it is getting diagnosed earlier than before. So yes, it can be diagnosed before 60. It can be diagnosed before 40, actually. It's rare,
Yeah.
but
Yeah, one of our colleagues online, Sonia, actually said that she had a white woman in her early 30s present with this condition.
yeah, it's possible.
So it does seem to be getting younger and younger. I I wouldn't be shocked. Back in my other lifetime, when I was still seeing patients, I do remember seeing younger patients presenting at the age of 30 with huge myocardial infarcts, and it seems as if conditions of what we would call the elderly are now becoming conditions of the young in this day and age.
Sure.
So even though you claim you bit off more than you can chew, Dr.
Sure.
Nevondo, you managed with 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 today's topic. And I want to say to you, thank you very much once again for your presentation. And we will see you in the future again for our regular orthopedics topics. And I just want to say to everyone online, if you have any other questions, please type them in, send them through to us, and we'll send them through to Doc and distribute them to everybody. So from me at Clinix and from everyone, thank you very well. And thank you very much and good night.
Right. Thank you and good night.